in the spirit of the ICS, it's good to have some discussion. So I suggest I ask for rejoinders from the group, and then we can take some comments from the floor. I mean, as you know, the blood is an unreliable witness, and Richard Turner-Royk and Patrick Bates, who was the treasurer of the Society for many years, clearly defined that many years ago when they first reported on video urodynamics based on the previous work of others. And clearly, urodynamics is the subjective interpretation of objective parameters, and symptom assessment is clearly the objective interpretation of subjective parameters. Can I ask you, Alan, I mean, you've heard this discussion, what are your views on this? Because clearly patients come to us with symptoms.
Based on my views and what I've heard, I think that it's perfectly okay to group their symptoms into some term that they understand and even their primary practice provider understands. Now, I don't know whether overactive bladder is the right term or not. You know, to me, it's all a matter of where do the afferent sensations come from. If they come from the bladder, then it's perfectly okay to call everything overactive bladder. If they don't, then it's not. Prove to me that they come from somewhere else. I mean, I don't see that there's any proof of that. And the interesting thing about doing urodynamics is show me that urodynamics makes a difference as to how we initially manage these people. I don't think it makes a difference at all. They come with a set of symptoms. They have detrusor overactivity, no detrusor overactivity, sphincter underactivity, no sphincter underactivity. We manage them the same way, exactly the same way. So under those circumstances, I mean, I don't really see a need to change the term unless we can come up with a better, all-inclusive term that describes something that the primary care providers understand and that the patients really understand. So I'm perfectly happy to group them into overactive bladder, even though I know that overactive bladder is not the greatest term in the world, that prevalence is not equal to the need for treatment, and that, my friends, that's our fault. Okay, we've let the companies get away with that for far too long. And if you think it's their fault, not their fault, it's our fault, all of our faults, as well as a lot of other things that are presented, you know, at conference. Someone needs to ask the obvious questions. You know, why do you list things in terms of absolute changes instead of percents? Why do you have to use such a complicated statistical analysis that I can't even get the statisticians at the University of Pennsylvania to tell me what you're doing to find a statistically significant parameter? I mean, that's our fault. It's not their fault.
Jerry, you've written a lot on this. What are your views?
Well, they're a bit different. To start with the definition, I'm perfectly happy with the term overactive bladder. I just don't like the definition. And I think the problem with the definition is that it's too restrictive. For example, if I urinate right now, and then over the course of the next hour, my kidneys make 60 milliliters of urine, and there's a gradual increase in the unpleasant feeling that I need to urinate, and then at the end of the hour, I said to myself, I've had enough, this is too unpleasant, and I go rushing to the bathroom.
Jerry, we've got limited time. What would you suggest as a definition?
I would suggest overactive bladder as
and how
basically just as it is,
yep,
without all of the restrictions, without without a definition of urgency. Let us define urgency over time the same way the Oxford English Dictionary define words. One second point about treatment: of course you don't treat people differently because you do the based on urodynamics, because you do them all the same way. The crucial part of urodynamics, in my judgment, is taking in the patient's sensations, ability to contract and relax the sphincter, exactly the same things that Werner took into account, that Werner was talking about. If you do that, then there will be different treatments. Some people you treat with behavioral techniques because they have good control mechanisms.
Jerry, don't you need to also have in the definition excluding other pathology? The bladder is an unreliable witness. And if we tell people just to say overactive bladder and treat them, based on the patient's definition, isn't that a problem?
No, overactive bladder is a symptom like headache. I have a headache, I could have a brain tumor, I could have a migraine, or it could be there's such a thing as a normal headache. And I think there's such a thing as a, quotes, normal overactive bladder.
Alan, do you want
10 cups of coffee.
Alan, do you want to come back on that?
I'm going to write this down because Jerry and I agree. So,
Excellent. All right. You want to speak, Werner?
Well, you know, I don't care what term the drug industry uses to market their products. And it may be useful with some patients to communicate this way. I find it misleading. For us, it's difficult to explain our old ladies when they have urge incontinence why they have an overactive bladder and they should do pelvic floor muscle training. But what I'm mainly concerned about is at a meeting like this, at a scientific meeting, this term should not be used because they are pretentious and not descriptive. We should be clear what we say and clearly describe what we find.
So would you prefer storage LUTs?
No, I think we have to be more specific. When you do urodynamics, you have to be very clear.
Yeah.
Is there an involuntary sphincter relaxation? Is there an involuntary detrusor contraction after that, before that? You know, as I tried to show on my slide.
I agree with you, Werner, but surely 95% of people don't come to urodynamics who've got these symptoms. Alan?
no, I was just going to say, you know, what is urgency when you have neither a detrusor overactivity or an involuntary sphincter relaxation? Because we see that all the time. So what is it? I mean, you know, that's the whole point, is you don't need either one of those to have urgency.
Werner?
Well, we don't see that. You know, I think the point is we don't look for it. That's the same with detrusor overactivity. We talk about it because the sphincter is ignored. If you do systematically, you will not find a patient in real urgency, that means fear of leakage, without something happening in the urodynamics.
Okay, Carrie?
Yeah, I think like the trend of ICS standardization has been to get rid of the organ-specific names if they are not organ-specific, such as prostatism. You don't use it then anymore. It's kind of illogical that you love the overactive bladder, but you don't like prostatism. And it's dangerous to give fancy names for all medical problems if we don't know that they really are like prostate cancers in prostate, breast cancers in breasts, and overactive bladder, is it in bladder really? But I think from like a scientific philosophical perspective, the most important thing that we just remember that it's not one disease, and we can maybe use it as a symptom complex, maybe not.
Thank you. Jerry, and then I'll come to Marcus.
Yeah, two points. First, we should all remember that urodynamics is a snapshot. It's one void out of millions in your lifetime. So we can't put too much faith in that unless it reproduces the pathophysiology. Second point, what you're talking about when you talk about the urethral relaxation was, as you pointed out, well known before. This is really the initiation, at least in my judgment, of the micturition reflex. So, and that's the first recordable event for that is a relaxation even by the EMG. So that's, whether you measure the bladder or the urethra, in my judgment, you're generally measuring the the micturition reflex.
I mean, we mustn't forget that urodynamics is a definition, and it's provocation, and it's not physiological. And what we use in the ICS is what we've recognized from the definitions. And so we must bear that in mind, so it's no surprise that it's sometimes difficult to relate, because if you do ambulatory urodynamics, which isn't defined, you get very different parameters, as we all know. Marcus, you're chairman of the Standardisation Committee. Do you want to make some comments? And then we'll come to questions.
Yeah, the sort of strength of feeling is huge, and at the moment we've got one of our most important initiatives, the standardisation, is not fully engaging people. So our intention now is simply to listen. In other words, what we're planning to do is to capture all these opinions and everybody's opinion. In effect, we're going to survey all this so that we can come up with the sort of judicious compromise to try to reflect the majority of feeling and incorporate the key elements which seem to have caused such strength over the last 10 years. So that is our initiative coming up from the Standardisation Committee for urgency, OAB, DO, frequency and other key aspects.
Okay, can I just take some comments from the floor? Can I just go from 1, 2, 3? I can't really see with the lights of my eyes. Please.
Yeah, just can I say that overactive bladder, the term, I mean, there's no evidence to suggest that the bladder is being overactive when you've got urgency. There's no evidence that the sensation arises from the bladder we cannot have a term that implies that. We need to get back, as Kerry has said, to a non-specific terminology. And indeed, I would challenge Marcus in the ICS standardisation group to come up with a better definition, maybe back to urgency frequency.
Thank you.
Dr. Lufgren-Sween, what about the hypersensitive urethra, which is connected to the normal maturation of the reflex?
Okay. Anybody want to take that?
Well, again, it's a mechanism. There are many different pathophysiologies described in patients and in basic science research which conceivably could alter the transition from sensory to sensation or the abnormal expression of lower urinary tract motor activity. So, hypersensitive urethra absolutely falls precisely into that category.
So, complex area. Can I move on? I'm sorry, but you've raised a good point.
Mary Bergmans, Maastricht, the Netherlands. It's not the key element, urgency, and urgency with so many different underlying causes of urgency. I hear about sphincter relaxation. Do we mean the urethra, the sphincter there, or also the pelvic floor, which would mean that the pelvic floor influence by, for instance, behavioral treatment or physical therapy can have a tremendous influence.
Well, of course, it can be. We don't know. What I just argue for, we should change everything which is just pretentious. We should be clear and descriptive. That's what I ask for.
Hi, Steve Finney from the United Kingdom. If I may use an analogy from another organ system, if we describe the overactive bronchus syndrome as a cough, with or without shortness of breath, usually with expectoration or wheeze, if we tell the patient they have that, they'd be jolly and impressed. Now, I think this analogy highlights the non-specificity, the fluffiness of our diagnosis, and I don't think that's through scientific lack of effort on the part of this society, more of a lack of scientific fact.
I think it's a good point.
It certainly doesn't imply a scientific fact. The problem is there are no scientific facts. Show me just one thing. Where do the afferent impulses come from? That's all. I'd like to know that, because that would be very helpful in applying at least some term to this. I mean, I don't think overactive bladder is a perfect term. I mean, I really don't. But show me a better one without having 74 categories of items, of which some are urodynamic and some are not, when right now the state of the art is start with non-invasive treatment that always includes behavior modification of some sort, and then go on to the more complicated. And to do that, initially you don't need urodynamics. It doesn't matter whether you have detrusor overactivity or sphincter underactivity. If you have urgency, which I think you can have without either one of those, how do you treat it? That's the problem.
The fundamental problem with all of the background to this is if you look at all the pharmacological research and the basic science research, is nobody can differentiate clearly between what's happening peripherally and what's happening centrally in many cases. And people either come from a peripheral standpoint with a small furry mammal that's had acetic acid in or obstructed, or they come from a central standpoint with imaging, which is rather crude, as we all know. So there's a lot of work to be done yet. Now, Richard, you've been very quiet, and you've been in the society for a long, long time, and a great wisdom. So do you want to put your thoughts and then conclude the session?
Thank you, Chris. I think we've had a most interesting series of discussions about the overactive bladder, and I was very pleased indeed that Carrie Tikkanen had mentioned prostatism, because it's quite interesting, isn't it, that in fact when an elderly female comes to us with frequency, urgency and nocturia, we are likely, in talking to the patient, to say you have an overactive bladder syndrome or group of symptoms, whereas if the same age man comes to us, we call it something to do with prostatism. And I think of the overactive bladder as something which I discuss with my patients. And I hope that they understand that what I'm talking about is urgency for fear of leakage associated with frequency and nocturia. In the same way, when I talk to an older man with prostate cancer, I may know that there are many different divisions of prostate cancer, but the short form that I use to my patient is that they have prostate cancer. And then we can go into more detail. Now, we have to start somewhere. And I think the general term, overactive bladder, is quite a good term for discussing it with those people who, with the condition, come to us for help, much as Alan has enunciated. I do think that we miss an awful lot of people who have a different type of urgency, perhaps associated in younger women with urinary tract infections. For they also describe urgency and have to run to the bathroom with their legs crossed, perhaps. And it's not the sort of urgency that we are talking about when we think of a bladder which is starting to contract, if that's what's happening on your front doorstep when you try and get your key in the front door on a cold, wet night, or the urgency that we might get when we're here running water, or the other things that Marcus has so succinctly drawn to our attention, which are altering our perception of what is coming from our bladder.
Thank you very much indeed, Richard. Nancy and Ralph, I hope that you feel that we've worked in the tradition of your husband, father, and we really do appreciate you coming to the meeting. And I hope you can see that the great esteem in which he has been held and will be held in the future. So thank you very much.